Well, everyone, good morning again. I have 10:30, so I'll call December 16th meeting of the Neighbors of Dunn County to order. Before we have roll call, I would like to say I'm sorry about the passing of County Supervisor and member of this committee, Sarah Kennedy. She truly had a passion for healthcare in Dunn County, and she will be missed. In roll call, I see we have Supervisor Kinnear, Supervisor McCulloch, County Chair Dave Bartlett, and numerous staff. I do not see anything. Anyone hear anything from Supervisor Jensen at all, or no? Okay. Approval of the minutes. I'm sure you all had a chance to read them. Motion made by Supervisor Kinnear.
Seconded.
Second by Supervisor McCulloch. Are there any questions on the minutes? And hearing none, all those in favor of approving them, say aye.
Aye.
Opposed? Carried. Do we have any public comment? Krista or Carmen? Do you?
I did not receive any.
Okay. At the request of the chair, I remember from last month, Chair Bartlett was kind of wondering if we could get a cost comparison of unfilled beds. And Carmen and I talked about this, and go ahead, Carmen. Did you find anything out, or?
Sure. I'm actually going to share my screen so that it's not just me reading off numbers. So bear with me. I'm on my desktop today, so I'll see if I'm skilled enough at doing this. Okay, can you all see this?
Yep.
Okay, so I can send this out to you as well because there's a description on the top, but that's basically describing what we have talked about in the past. That if we basically, the question was if we could raise wages to a certain dollar amount, and hypothetically saying that that would fill all of our open positions, allowing us to admit more residents to the neighbors. At what point is that like a break even point, or would it be financially sustainable to do so, of how much to add versus how much we would be increased in revenue for filling more beds. Obviously, this comes with a lot of ifs. It's if we can raise the wages, if we can get more staff by raising the wages. Wage increases, I'm sure, would be helpful. It's also not the only reason for the shortage in staff. There's simply just not enough people. So there's a lot of ifs in here, but it is the dollar amount breakdown for all of the different scenarios, just to have as options. I worked with Jenna and HR on this to figure out the cost of increases. So it does include taxes, WRS, everything like that. We did an increase of $5 per hour, and what that would equal. So that would be $1,035,187 roughly for 2022. It would be solely the increase of the $5. So that would be in addition to the already budgeted staffing costs. And that would to the budgeted amount of staff. And then not actual, but budgeted, as though we would hope that that would be filling more positions than actual current. As well as we did the additional $2 per hour, which was that 414,000 there. Then we also calculated the revenue for increased census per request. We calculated it at the Medicaid rate, as we would hope that we would get some private pay, Medicare, VA, any of those better paying sources. But the only guaranteed rate that we could get if we filled a bed would be the Medicaid rate. So we calculated it at our average Medicaid rate. So the 256 is the average rate if you average out our 3 current Medicaid rates. Our current census has been roughly 90. So we took that 90 residents, and if you increase it to 95% census, as 100% census would be unrealistic, even if we had as many referrals as we could. There's always days that are turnover, things like that, filling a bed, cleaning a bed, things like that. So if we raise it up to 95 census, so that's 130 residents, that would be 40 more residents per day than what we're currently operating at, roughly. And that's times the $256 would be $10,240 per day. So since we did the calculation of the cost for the staffing at a year, we did a year for the cost of what we would, or the potential revenues that we would make if we were 95% full. So the additional revenues that we would make compared to being at 90 residents is $3,737,600 in additional Medicaid based on the averaged Medicaid rate currently. So then we compared these numbers as well as our cost report numbers. So working with Jane, figured out based on our current cost reports from 2020, that's our most recent numbers, and that's how our 2021 rates are set. We're not to 2020 rates yet. So currently our empty bed costs, so that was a question of how much does it cost us to have an empty bed, is $132.70 per day. That's based on overhead costs and things that are fixed costs that we can't change, based on how many residents are in the building. It's going to cost us that much. And that's $132.70. Roughly our cost per day for a currently staffed bed is about $320. That includes that fixed overhead costs, our staffing costs, food costs, basically what it costs us to take care of a resident without factoring in the other things that could be more expensive, like wound care and things like that. So it's roughly $320 per day. Currently we are getting, so if that 256 plus we do get the supplemental payment and things like that, but even that out a little bit more, if we were to increase to that $5 more per hour increase for a staffed bed, we would be at about 245 costs per day. We calculated out that $5 spread across per patient day would be about about $24 a day would be per patient day. And that would be about $345 a day. And then that would be at a $70 a day loss once we place in what we get from Medicaid, what we get from supplemental payments, and other basically payments we get for those Medicaid residents. So it could potentially, if we increase the wages by $5 per day, and that really did result in filling all of our staffing positions to the point that we could admit and fill the building to 95%, could potentially lower our loss down to $70 per day on a Medicaid resident compared to the $132.70 per day that we are losing to have it empty. As I said before, there's a lot of ifs in that, but it does potentially show that it could make a positive difference if we were able to hire based on having $5 extra a day. So that's kind of the analysis on that. Like I said, there's a lot of assumptions in it, but it could potentially make a benefit. Do we have questions?
Yeah, I do. So you don't think that you would be able to hire enough staff at a $5 an hour increase? Just your thoughts?
I think it would help. I don't think it would solve.
I mean, you wouldn't get enough help to have the 130 residents at 95% census, correct?
I can't answer if it's gonna happen or not. I think it would help, but I can't say that it's gonna solve the problem. There's just simply not enough people that want to do this work. And the other thing is it's just a revolving door. If there's any sort of, I don't like that, whatever it might be, they can go to the next place. And at some point when we keep raising wages, and I'm not saying we shouldn't do this, but it's just every building's just going to keep costing each other out because we raise it, ALH raises it, we raise it, they raise it. At some point, it's just going to become which place can sustain it longer than the other.
Yeah.
But I do think it would help. I just can't guarantee that it would fix. And I don't want to put the illusion out there that we do this, it fixes the problem.
Yeah. Yeah. Are there any other questions? Dave, I can't see you if you have your hand raised, but.
I didn't have my hand raised. I'm still taking in all this information and thinking about it.
No, I can.
I would ask if you could email that out to us so we could think about it more. I think it really gives us something to think about. I actually thought the difference would be more than the $40 or $38, whatever it is, or what, 70 to 132 you said? So it's 50 some, 48.
70 to 132. Yep.
Yeah, so $48 a day per bed. I thought it would be more than that. But that's why I asked you to look at it.
And there's a lot of different factors that aren't placed into this as well. We did all use Medicaid as that would be the only guarantee. So we could potentially and would hopefully fill those beds partially with Medicare, potentially private pay, whatever it might be. Currently, we have hardly any Medicare census. We have started to admit a few here and there, but those do pay higher. They do cost more, but it all offsets a little bit. So there's a lot of different things that make this very rough numbers. It's not exact by any means, but it is as close as we could get.
Right. And I appreciate you doing this for us because I really think it gives us something to think about. If we don't do anything, I don't know that the future is so great. I think we have to think about doing something.
Mike, you had a question?
Well, I think maybe I was following up on your train of thought that 95% might be a little unrealistic, whereas 90 might fit a little better. But we could, from the numbers you send us, Carmen, we can extrapolate that.
Yeah, and so the first part was calculated on overall costs and whatnot, but the bottom half of that is all by per patient day. So that could be fairly easily calculated into less residents or more residents, because that was all per patient day.
May I also add that when it shows that we're losing $70 a day on the bottom of her calculations, that includes cost report numbers. That's not our cash flow numbers. That includes depreciation and building costs and things that aren't part of our cash flow. So I would be careful in publicizing that number. It's not the same as our cash flow.
Okay, yeah.
Yeah, we use cost report because that's our best option of figuring out the numbers across things, but there's always different things calculated into that as well. So we're a little bit limited on trying to figure out the best way to calculate it. And that was the current most accurate, but yeah, there's a lot of rough estimates in this.
Okay, are there any other questions? And hearing none, well, we'll carry on, but thanks a lot, Carmen, for putting that together. That's you and your staff, so thank you. We'll go into your administrator report then, please.
Okay. First is the Quality Assurance Steering Committee updates. So we met last week for quality assurance. We went over our surveys because that was a big part of our last month, which we already discussed last month in this meeting, but it was part of that. As well as we did have our new temporary medical director there for a meeting for the first time. So that was nice. So Dr. Richard Nagler is currently our interim medical director. Mayo is changing some of their processes and policies in regards to nursing home care and how they manage medical directorship. So we're still kind of waiting that it might change to someone else and be a different setup, but we're waiting on them. It's a system that they have used in Rochester area before, and they're looking to implement it in our area with the Chippewa Valley region. And they thought that we would be a good facility to kind of test that out at, since we have a very longstanding tradition with Mayo and work with them for a lot of things. So we'll be doing that, but for right now, Dr. Nogler is our interim medical director, so he was there. So it was nice to have him at that meeting. Besides that, there is nothing very new or exciting from that meeting. Nothing that came up that was anything noteworthy. So any questions on quality assurance? Okay. Next, the employment activity report. So I'll have Chris do that.
Morning.
Morning, Chris.
So on the employment report that I had sent out, lists the number of interviews. We had 7 interviews scheduled. We held 6 interviews. Positions offered were 6. Positions offered or accepted were 5. We didn't have any licensed staff that we offered above a step 3-2. For resignation reasons, we did lose a couple part-time CNAs. One reason was kind of uncertain. The other one stopped coming to work. Then we lost a couple of part-time homemakers. The one stopped coming to work, and the one had reported that the work was too hard on her body and decided to resign. We go down to open positions, so those were adjusted a little bit. So for the month of November, we're always reporting a month behind. They were adjusted. For the month of December, we were able to gain a couple of agency LPNs and a few more agency CNAs. We skip down to active leaves of absences. Total, we have 24 active leaves of absences, education, FMLA, that type of thing. Work comp lost hours. We did not lose any hours for the month of November. And then if we go down to shifts missed due to COVID-19 issues, we missed there were probably approximately 40 shifts missed due to COVID-related issues, or approximately 310 lost hours. That's the employment report in a nutshell. Do we have any questions? Mike?
Yeah, thank you. I just a few things. I was looking at a year ago for the open positions.
Okay.
And it was about half as many as we have now, which is all right across the board. Not exactly, but so we have fewer people, fewer residents, and way more open positions than a year ago. Is that right? Okay, so it's not a good trend. Is that what I'm seeing? Okay, I just want to make sure. And I'm looking down here at the number of shifts missed to COVID. Last reporting was 24. Now it's 40, and a year ago it was 90. Are we heading up towards the 90 again? You can talk about that later, maybe when you talk about COVID, but.
I can address it now if you'd like. Yeah, we are trending up. I don't know if we'll go as far as the 90. I hope not. We are trending up, though. We have seen handfuls of cases more often now than we had in the past. Summertime, we were doing really well. We didn't have hardly any throughout summer, actually. And now we are, just like the community as a whole, cases are trending up. We fortunately have not had any resident cases, but we have had a few staff cases here and there. Not nearly as close to last year in November timeframe. That was by far our worst, but it is much worse now than it has been.
Yeah, thank you.
Any other questions for Chris? Hearing none, we'll go to resident referral report.
All right.
Thanks, Chris.
So the resident referral report looks similar to last month. So we had 93 residents at the beginning of the month. We had 125 referrals. That is a lot. It is primarily because nowhere is accepting. That is what the trend has been. We're getting referrals from all over the place, and we're getting them every day. So it's similar to what we talked about last month, that very few nursing facilities are accepting. And if they are, they're accepting one referral just to fill a bed that was, someone had passed away, someone discharged. They're keeping their census as low, similar to what we have been doing primarily due to staffing. The other contributing factor is COVID. We have had seen other nursing homes in our area have COVID outbreaks within their facility, limiting admissions and things like that because of COVID as well. So we still are not able to admit to a household or in other skilled nursing homes to an area, if it's a hallway, household, whatever their setup might be. Nursing homes are not allowed to admit to those areas if there is a COVID outbreak, whether it's staff or residents. So the increase in COVID-19 cases is also causing lack of ability to admit on top of the system-wide or systemic staffing issues. So that is why we see that many referrals. It is a lot. And unfortunately, we are not able to capitalize on that and admit people. We did have 3 admissions this month, but they were all readmits. So if we send somebody out to the hospital, we bring them back. We do readmit them to the facility if they go out to the hospital. So we had 122 not admit. So 3 of those 125 were our readmission referrals. They weren't new ones, but they do count as a referral. As noted in the past, we also don't always accept all of them. So we on average have accepted about half. If we were able to admit, we would have potentially accepted about half, not quite, because that's still a lot of residents. We probably would not have admitted 60 residents in a month, but we do admit about half typically. At the end of the month, we had 90 residents. We had 0 transferred to another facility. We had 2 deaths and 1 discharge. So, or 0, that must be one number off. We had 2 deaths. It must be off by a day. So we would have had 1 discharge. And I am happy to say that we have started to admit to our open beds in our outer buildings and trying to fill those beds as people leave. So we still have the 2 closed households, Fireside and Arrowhead, but we are admitting to the households in the outer buildings. By closing Fireside, we were able to free up the staff members that were keeping that open for 1 or 2 residents to go and be fully staffed in other households, allowing us to be fully census to be fuller in those households. So instead of having 1 CNA and a nurse, we're now able to have the 2 CNAs and a nurse to be able to properly staff to fill a household. So we are admitting to our outer buildings. We're at a 93 census right now. We have had I believe 3 admits in roughly the last week and are continuing to do so. We do currently have a few households that are not able to admit due to COVID positive staff. So that is limiting us also at this point. Hopefully by the next week or so, if we have no more positives, we'll be able to admit to those households as well. Questions about referrals?
Mr. Chairman?
Yes, Paul, go ahead.
Carmen, I was struck by your statement that nobody's admitting. And I understand, you went over some of the reasons, but you mentioned again, the staffing issues. Presumably that includes areas that pay higher than we do. And I'm relating back to the earlier discussion about raising our pay. Does that at all reflect the chances that we actually manage to attract additional staff if we raise our pay, if in fact the staffing shortage is affecting even those that already pay more than we do?
It could. I think the idea would be to, if we raise the $5, that would be raising it to the most, and then we'd attract more. So I think, like I said before, I think we would attract more. I just don't know if it would be enough to be fully staffed. I'm not sure. It also depends on other people's factors. If you work somewhere for 30 years, you may not leave, even if there's pay somewhere else, or if there might be other factors, drive times, things like that, that would maybe not have as many people leave, but yes, it's pretty much everywhere is very short staffed. One of our guidelines for participating in one of the state programs that actually is intended to get you staff through an agency that's partially state funded that we participate in, we have to fill out this available bed online website kind of thing, and you can see all of the region and available beds and whether or not people are admitting. And there's very, very few that have what they consider available beds. And in the comments on most of them, it says fully census full compared to amount of staff or something like that. So it is pretty widespread. And I hear it from my counterparts at other facilities as well, that it's they're just halting admissions at this point. There are a few nursing homes that are admitting even without the staff. We have heard some stories about that. And then there are probably a handful that do have okay staffing, but that's not the norm. The majority of us are in the same boat.
So one other follow-up question. We focus on attracting new staff when we talk about raising the pay, but if we raise the pay, we're going to have to apply it to our existing staff as well.
Correct.
So there is a known cost, presuming we hang on to the staff we have, associated with raising those salaries that constitutes an additional cost that doesn't increase our census at all because it doesn't actually change staff. Are we able to break out that addition, that part of that, what was it, $1.3 million? Are we able to break out the known portion for existing staff that we will have to absorb without knowing whether or not the raise in salaries will actually attract more staff?
I can work with Jenna on that. She helped me with those calculations to get the WRS part of that in there. So it would probably be like a point in time snapshot of current
Right.
staff, because we wouldn't be able to, it'd be however many staff we currently have. So it
Right.
would be another rough number, but we could get that.
I think that might be an important additional piece of information to provide the committee as they digest and think over what you presented earlier. And, you know, I'm sorry if there's a little bit of field of the referrals, but obviously it's all tied together. So.
Yeah, we can work on that.
This is kind of off the subject a little bit, but what are these people doing that aren't getting admitted? Where are they going?
That's part of the struggle that we're having with the hospital systems, that they're full. So the
They're going
hospitals are
back to
full.
the
So it's an
Damn.
added part of this whole problem in general with the healthcare industry right now. So COVID beds, and then people not being able to admit to nursing homes, they're staying in the hospital, which obviously the hospital system doesn't like very much either. So there's a lot of issues with it, that something's gonna come to a head before it fixes itself, I think, because all of the hospitals are full, and they're keeping them there, and that's costly to them as well. But yeah, so they do have a lot of our, especially our local hospitals, if they're like a critical access hospital, have what's called a swing bed. So they basically bill like a nursing home for Medicare there, but they only have so many of those. So it's part of the reason that there's not enough hospital beds.
Thank you. Anybody else?
I think, Brian, more people are going home too and relying on home care.
I would
Self-pay
understand. Yeah,
stuff.
I
Yeah.
guess they would
Even
be,
when
yeah,
they, yeah,
but,
even when they're on the borderline of being able to go home, but they'd rather be
Yeah.
home than sitting in the hospital.
no, I understand totally, but some of them can't do that.
And I'm sure the hospitals are seeing an increase in readmission rates too, because people are not having the safest discharge plan from the hospital. So that's bottling everything up even more.
Thank you.
Any other question on referrals? Okay. Next.
Dave?
Oh, sorry.
Sometimes we talk about our amount of staffing per resident, and you've mentioned in the past that private pay or some places have more residents per staff than we do. Is that a big amount, or, I mean, I guess I'm wondering if we were to stretch our staff like a private pay, and would we be able to admit more residents or not?
So there's a couple of things that make that difficult. Partly because we ask our CNA staff to do a little bit more than what a traditional CNA staff does. They help with serving meals, they help with laundry, housekeeping, stuff like that. So that is part of why our ratios are higher, is because we truly do have closer to a universal care worker setting instead of separate laundry and housekeeping and all of those different positions and then CNAs. And then secondarily, because of our setup of our households, it's very hard to have them split households. Because when you're talking about a big, long nursing home, like the government center, when it was the healthcare center, it was much easier to have people moving from place to place. But because of our physical structure of how far apart those households are, it's very difficult to have more residents to less staff. Otherwise, you would only have one. The only way to do that is to have one CNA in each household and then like a float. But then there's not enough people there to then assist with two-person transfers and things like that. So partly because of our physical structure, that's not very feasible. And then secondarily, because of we ask them to do a little bit more too, as more of a universal care worker. So there are places that do have more residents to number of staff, but they have different settings there as well.
Okay, thank you.
Good. I'm sorry to keep it going. Could I follow up on that, please, Mr.
Absolutely.
Supervisor? Okay. I'm just curious, now that we have fewer residents, how about the staff? Are there as many mandatory shift requirements, as much overtime as we've been having? How's that working out as far as requiring them to do things?
It has been better. So as Chris had said, we did have a few more applicants and interviews this month, as well as less turnover. So we have increased the number of staff that are currently in the building as well. And it has gotten better. We've had less issues with having to mandate people to stay. People are still picking up if they would like to, and we've asked people to pick up, but there's less situations where we've had to tell people you have to stay.
Have you noticed, maybe it's too soon, but any maybe change in attitude or atmosphere where, oh, gee, this is not so bad. It's a little nicer place to work without the mandatory things?
I would say any instance where we don't have to tell someone they have to stay, they're definitely happier, especially on the one-off situation. It might be a little bit too soon to tell as a whole situation, but in the instance of that they don't have to worry that their next shift that they might be there for however many extra hours, I think, yes, people are in general happy about that.
Well, that's kind of what I hope happens, is you have a good atmosphere, and then it's easier to hire people, and then you can keep them more easily. And so, thank you. I appreciate it. I'm done, Brian.
Okay. Anyone
Any
else?
other questions? Okay, next will be Scott for the environmental.
Morning, Scott.
Good morning, everyone. Not a lot from me to report. Things have been running pretty smooth. A few normal issues with heat pump problems as usual getting into the cold weather. We got our Aeon unit fixed for the kitchen, so they're back up running toasty warm. Working on some ways to find out more information on this geo system for these heat pumps to try and run more efficiently and have less of these breakdown problems. So we get a handle on it more, working with some different people and getting more ideas. So that's happening. Otherwise, our major thing that went on was the federal look back survey, which Carmen is going to speak more on, and I'll jump in when I need to on that. Otherwise, things are moving good. Our first major snowfall went good. everybody got everything moved. All hands were on deck, so that went well. Otherwise, nothing major. Anybody
Must
have
have
any
did.
questions?
Yeah, you must have did well with that snow removal. I don't see any around anymore, so.
It's all going away, isn't it? We scared it away, right?
Yeah.
So would this be a time to ask a related question of facilities?
Sure.
Sure.
Maybe this is from Paul, or also, I just wondering about what I read in the facilities packet. It said a market value study for the neighbors. And I'm wondering what that was, Carmen or Paul?
We took advantage of an offer from a firm that is in the business of selling nursing homes to do a market evaluation of the value of our nursing home as a piece of information, just to keep in our back pocket. It is always an option, although not a preferred one, to say we're out of the business. And if we were to exercise that option, we need to know what would be the consequences. We're still paying the bonding on the neighbors. So for instance, when we did this a few years ago, 4 years ago or so, at that time, the value that we could have gotten by selling the neighbors potentially would not have equaled what we still owed. So those kinds of decisions are part of what we need to be aware of, just in terms of being informed. So we had an updated one that we got just to get a handle on today's market.
Good, that's what I thought it was. I remember the last one. And what did it tell us?
The value, surprisingly, despite the various problems, staffing and otherwise, value has gone up. The market value appears to have gone up. So it's something that we may, as a committee, talk about in the future. I don't believe it's appropriate at this time. I would hate, for instance, for it to go out to staff that, gosh, the committee is talking about selling the neighbors, because we're really not. This is a matter of doing our due diligence and having facts in our hands for the evaluations for overall considerations.
And we also have to
Thank you.
remember,
Thank
we
you.
also have to remember was estimated value.
Absolutely.
So. Okay, anybody else? Move on to the central survey, please.
All right. So last month I reported that Central had their annual survey. So they had their annual survey for both health and life safety code. Something that can occur post surveys is a federal look back survey. So basically what that means is that a federal surveyor out of the Chicago region, so the Chicago CMS or federal CMS, it oversees most of the Midwest. And so they would be our survey region, comes and does what's called a look back. So they resurvey the building. We received a federal look back survey for Central for life safety code. So they don't come and do the health side again, they'll just do one side of it. So the federal surveyor was here 2 weeks ago and did a one-day survey similar to what the state surveyors do. Typically, federal surveys result in a lot more citations than state surveys do. Keep that in mind. So we did receive a few minor citations from the federal survey, all of them fairly easy fixes with the exception of one of them, which we're actually questioning the surveyor on to see what regulation was being cited, as both myself and the state surveyor cannot figure out where in the regulation the cited rule is. So we are still working on that. That we got our statement of deficiency earlier this week, and I reached out to the federal surveyor pretty much the next day to ask a couple of questions about 2 of the citations. So we did receive in the statement of deficiency 5 minor citations for life safety code. So they all were fairly easy fixes, like I said, besides that one. The one citation in question was where an enunciator panel was. So we have the right enunciator panel and it's in the building. It does what it's supposed to do, but he did not like where it was located. And we're trying to figure out where in the regulation it says that it needs to be located in a specific place. So we're working on that one at this point, as well as a couple of the other ones that we just had some questions about. So it was an interesting process for everybody, but all in all, he even said when he left that it was a very good survey, even with the 5 citations that he had given us. So it could have been worse. And now hopefully we don't have any more. Is there
Good.
any questions on that at all? So it's only a small portion of facilities every year get them. I believe each region is supposed to have a certain percentage of the buildings that receive federal lookbacks or federal oversights. There are 2 different kinds of federal surveys you can get. One is what we had, which is the look back, which they come after the surveyors were here, versus an oversight would be when they come at the same time as the other surveyors. When they come at the same time as the other surveyors, they're actually kind of surveying the surveyors to make sure that they're doing what they should be doing. But this is truly a survey of the building. And I will give an updated report on that next month after all of the plan of corrections and discussion about the citations is completed, and let you know what came of all of that as well. All right. Next is the COVID-19 update. So we already talked about this a little bit, but we have seen an increase in COVID-19 cases in staff, which is not surprising with the COVID-19 situation in our county as well as our region as a whole. We have seen quite a few staff members test positive. We have a 1 or 2 a week probably at this point, as well as people that are close contacts. And there has been a fairly nasty upper respiratory cold going around that a lot of people have got. So that requires staff to be out and be tested and all of the things that come with that, since it has very similar symptoms to COVID. So we have had quite a few staff out sick over the last couple of weeks, if not month, with an upper respiratory issue that we don't want that to be given to residents either. So it's all in all good to have them out of work at that time anyways, but lots of people getting tested, which does take away from staff even if they aren't COVID positive. So we've seen an increase in that as well as increase in other illness. As a whole, nothing really has changed in the COVID world for regulations. I believe last month we talked about visitation. So CMS did change the visitation guidelines, basically to say we can't restrict visitation. So which is a positive thing for our residents. Basically saying if there's an outbreak, people who are visiting have had the opportunity to be vaccinated if they would like to be. So if they're coming into the facility when we have a quote unquote outbreak, they're entering at their own risk kind of thing. Instead of saying, no, you can't come in, we're letting them make that decision if risking coming into the facility is worth it to see their loved ones. The only time that someone is restricted from the facility is in the scenario that they are either COVID positive, they had close contact with someone, or they are symptomatic. So basically, anytime that we would keep somebody out if they were an employee, we would also keep a visitor out for those same reasons. So, but besides that, they are allowed to come in. As far as other COVID things, I'm not sure if anyone saw the news yesterday, but there was quite a bit of talk about the COVID vaccine mandate and the court cases that are currently out there by different states. So as of right now, it does not change our practice towards the COVID-19 mandate. Subsequently to the lawsuits and court cases and appeals and all of that that came out from all the different states, there was also a memo issued by CMS on December 2nd, I believe, stating that as long as there is litigation going on about the vaccine mandate, they will not be surveying it. So they won't be enforcing it no matter which state there's holds on or anything like that as of right now. They could obviously issue a new memo and change their minds on that, but currently they are not enforcing it, even if your state isn't covered by one of the hold orders. So right now we are not in potential of being surveyed or audited or enforced for the vaccine mandate. So even though Wisconsin is not currently covered by one of the hold orders. Besides that, I think everything else has pretty much stayed the same in the realm of COVID. It's still out there. We're still having all the precautions, and there's still significant risk. So,
Any questions? Dave?
So does that mean that the people that are working at the neighbors don't have to be vaccinated?
Currently, no. Currently, they're not enforcing the regulation that CMS had out there because of the litigation. Depending on what happens with the litigation that is currently out there, that could change. So basically, when they put in the original vaccine mandate, there was certain days that everyone had to be mandated or vaccinated by. Then a bunch of states filed lawsuits, stay orders, hold orders, all those different things, all the different litigation, and that put everything kind of on a freeze. We did have quite a few staff members submit exemption requests and things like that as well. We did have some people get vaccinated that weren't, but at that point when Wisconsin was covered by one of the stay orders, per legal counsel and HR, everything kind of stopped at that point. Now, yesterday's the 11th Circuit Court of Appeals, I believe, was the correct court, basically pushed it through so that that was the one that covered the whole country. And based on what I read in my interpretation, I'm obviously not a legal expert, but it was basically saying that they couldn't file the stay order for the whole country. I believe it was Louisiana that tried to, and they said that that's not how it works, basically. So then that order was considered invalid, that stay order, but there is still 24 states that are covered by a different stay order that's still in litigation. And because of that, per CMS's guidelines and their memo, they will not be enforcing it until those are finished. So once those are finished, depending on the outcome, either CMS may change their order or something, we don't really know. But once that comes out, then we will be doing whatever the regulation is at that point.
So our policy is we're doing anything they tell us to do.
Correct.
Okay.
Mhm.
Mike?
Dave asked the same question, so he took care of it. Thank you.
Yeah, so at this point, we're doing whatever CMS says we need to do, which was vaccinating as many as we can at that point, and then obviously processing any exemptions and going through that whole process, but that was halted by all of the litigation and everything. And I believe CMS, when they issued that memo, it was they are a federal organization, so my assumption would be that they would like to keep it even across the board, especially since their regions oversee different states. So like I was talking about the federal surveyor that came here, he oversees us, but he also oversees Illinois, Iowa, Minnesota, different parts of the Midwest. So if he was going to different states to survey that had different stay orders, it would just become a mess. So they just kind of made a blanket statement saying we will not enforce until all the litigation is done.
So this, I realize that you may not be able to answer this question but some of the hospital systems decided to make all their employees get vaccinated.
Mm-hmm.
Have they changed their policy, or is that still their policy?
I believe that Mayo's was pre-vaccine mandate from the government. So I do not think they have changed their policy. So it depends on if they did it in reaction to the government telling us to do it, or if they did it on their own. So a lot of the hospitals did it on their own. We were doing it because CMS told us we had to do it. So then when they said you don't have to do it, then we stopped doing it. So that would be an option we could have, is to do it on our own, depending on CMS's outcomes, but that's another whole policy, and making everything depending on if it's county policy versus NDC policy and all of those different things. But our current vaccine mandate that we had was due to the CMS guidelines from the Biden administration. And
No, I wasn't thinking to change our policy. I was thinking maybe we may gain more employees. So
we could.
that's where I was thinking from.
And that is the primary driver in why we haven't had our own vaccine mandate, is simply staffing and numbers. There are not very many nursing homes that have done it. I know some of the larger systems nationally have done it. I believe Good Sam did, which is a very large skilled nursing facility system across the country, but there's very few, and I don't think there's any locally that have done it on their own.
Any other questions for Carmen? You have anything to add, Carmen, to your report, or?
I think that's everything.
Okay, we'll go to number 7, consideration for action to be taken by the committee. Review the vouchers. We all had them previously. Anybody have any questions on the vouchers? Hearing none, we'll go right into Jane's financial report.
Good morning, everybody.
Morning.
The reports that I presented or provided, the census report, of course, shows more Medicaid, less private pay, and that trend is continuing. We picked up one more VA contract person this month, so that will help a little bit too. But the payer splits are still continuing on that track of more Medicaid, which will be okay because the Medicaid rates have increased, and our supplemental payment is based on the number of days of Medicaid. So we're not so worried that that is the new trend. Pool staff report. It is what it is. There's one typo in there on the 2021 monthly average, kind of in the bottom right-hand corner, not the very bottom, but the 129,472 should be in that big box and the item above it. So the 2021 monthly average is 129,472, which is less than last year's monthly average at this time. The aging report looks a little bit different this time. If you look at the numbers under the November column, you'll see some negatives in the 61 to 90 days and the 91 to 120. That is because we recalculated some Medicaid contractual amounts and reposted them in order to clear up some reporting for the auditors. Our contractual accounts within our software are merging too many different types of contractual allowances. So we cleaned up that, and that is why that's there, showing more in the current category than actually occurred. So there's a little flip-flop there. The bottom line is we're at less than $1 million in aging. Our Medicare payments came in, they squeaked in before the month end close, so that's good. And also because our census is lower, we don't have as much to bill. Staffing, as far as collections go, I always tie that into my staff. We did hire our new biller starting January 3rd. We are short a biller now. My temp has taken different employment, and we'll get through it, but it's going to be short term, and then we'll be in full swing of training new biller and the other newer biller in January. So we're still in training mode, but I think we'll have a stable staff. then the financials. Points to highlight, senior meals are still strong. We have $147,000 in revenue. And if you compare that to the $114,000 in expense, that's a good balance to have. I did not post any additional COVID reimbursement. I'll wait until January and do all the year-end adjustments. They're complicated. So I want to do one mass adjustment, and that would include lost revenue, looking upwards of, $500,000 or more to add to our revenues. But of course, we've had those costs embedded in the expense side. Depreciation again is factored into the bottom, and the depreciation that is posted is within the property ownership and use category. And it looks, very similar to last month. The bottom line is good when you look at the COVID dollars that are added in. But we're still below our projections in revenues and expenses. Any questions?
Anybody have any questions?
Thank you.
So no questions for Jane. Is there a motion to accept the vouchers and the financial report? Supervisor McCullough moves. Is there a second? Second by Supervisor Kinnear. Are there any other questions at all on the financials or the vouchers? And hearing none, all those in favor say aye to approve.
Aye.
Opposed? Carried. They're approved. I guess we're about to the end. I've got just one comment. I have not gotten recently married like Carmen did, so I didn't really change my last name. So we'll have to put that back to Johnson. I don't know. Other than that, nobody has anything else. This meeting is adjourned.